Hepatitis C. Jennifer L. Bauer, MD. Christopher Lynn Brand, MD. Basics description. Hepatitis C virus, HCV, is a systemic viral infection, acute and chronic, primarily involving liver. Epidemiology: highest incidence between ages 20 and 39 years, highest prevalence between 40 and 59 years of age males and non-Hispanic blacks. 1. 4 drug use accounts for 70% of new HCV infections. Geriatric considerations: patients greater than 60 years are less responsive to therapy. Important to initiate treatment. Early pregnancy considerations: routine HCV testing is not indicated. Vertical transmission: 6/100 births, risk doubles with HIV co-infection. Breastfeeding is safe if no cracks or fissures. Pediatric considerations: prevalence, 0.3% test children born to HCV-positive mothers with HCV AB at 18 months or HCV RNA at 1 to 2 months. More likely to clear spontaneously, slower rate of progression. Incidence of acute HCV infection increased nearly threefold from 2010 to 2015. In 2015, there were 2,436 cases of acute HCV reported to the CDC, with an estimated 33,900 total new cases in the United States. Prevalence: approximately 3.5 million persons in the United States have chronic HCV, AB+. Prevalence highest if born 1945 to 1965, 2.6%. 1. HCV-related deaths are more common than HIV-related deaths. HCV is the most common cause of chronic liver disease and transplantation in the United States. 6 known genotypes, GT, with 50 subtypes. GT1 is predominant form in the United States, 75%. GT predicts response to treatment. Etiology and pathophysiology: single-stranded RNA virus of Flaviviridae family. Risk factors: exposure risks, chronic hemodialysis, blood/blood product transfusion or organ transplantation before July 1992, hemophilia treatment before 1987, household or healthcare-related exposure to HCV-infected body fluids, 1.8% risk. Children born to HCV-positive mothers. Risk behaviors and/or medical conditions: prior history of injection drug use, intranasal illicit drug use, history of incarceration, tattooing in unregulated settings, high-risk sexual behaviors, HIV and hepatitis B. Infection. General prevention: primary prevention, do not share razors/toothbrushes/nail clippers. Use and dispose needles properly through harm reduction programs. Practice safe sex. Cover cuts and sores. Secondary prevention: no vaccine or post-exposure prophylaxis available. Substance abuse treatment: reinforce use of barrier contraception for HIV seropositive co-infected with HCV. Assess for degree of liver fibrosis/cirrhosis. Commonly associated conditions: diabetes, metabolic syndrome, iron overload, depression, substance abuse/recovery, autoimmune and hematologic disease, cutaneous manifestations, necrotizing vasculitis, mixed cryoglobulinemia, porphyria cutanea tarda, lichen planus, erythema multiforme, erythema nodosum, HIV and hepatitis B co-infection. Diagnosis: history, determine exposure risk. Detailed social history, including alcohol and drug use, psychiatric and medical comorbidities, and co-infections. Chronic HCV: most cases are mildly symptomatic, nonspecific fatigue, or asymptomatic, elevated alanine/aspartate aminotransferase ALT, AST. Acute HCV: if symptoms develop, rare, onset typically 4 to 12 weeks post-exposure. Jaundice, dark urine, steatorrhea, nausea, abdominal pain, right upper quadrant RUQ, fatigue, low-grade fevers, myalgias, arthralgias. Physical exam typically normal unless advanced fibrosis/cirrhosis may have RUQ, tenderness/hepatomegaly. Spider angioma, caput medusa, palmar erythema, jaundice, gynecomastia, terry nails, arthralgias/myalgias, neuropathy, glomerulonephritis, livedo reticularis, lichen planus, pruritus, Sicca syndrome, Cold agglutinin disease differential diagnosis hepatitis A or B, Epstein-Barr virus, EBV, cytomegalovirus, CMV, alcoholic hepatitis, non-alcoholic steatohepatitis, NASH, hemochromatosis, Wilson disease, alpha-1 antitrypsin deficiency, ischemic, drug-induced, or autoimmune hepatitis diagnostic tests and interpretation initial tests, lab, imaging, screen adults born between 1945 and 1965, those with exposure risks, current and former 4 drug users, HIV-positive individuals, people who engage in high-risk sexual behaviors, partner either HCV-positive or 4 drug user, multiple partners, or unprotected sex, and patients with persistently elevated ALT. CDC algorithm HCV AB if non-reactive, no further action unless exposure within last 6 months is suspected, test with HCV RNA. If reactive, test HCV RNA. HCV RNA if not detected, no current HCV infection, no further action. 2. AHCV AB detected 3 to 12 weeks after infection. HCV RNA detected 1 to 2 weeks after infection. RNA detectability precedes ALT elevation. AST/ALT, often normal, but elevations may persist in chronic HCV. ALT usually is 1 to 2 times upper limit of normal. AST may be normal/elevated. Acute hepatitis C can elevate transaminases and bilirubin, direct and indirect. AST/ALT ratio greater than or equal to 1 associated with cirrhosis. If AST/ALT ratio greater than 2, rule out alcohol abuse. Persistent HCV RNA greater than 6 months equals chronic HCV. Follow-up tests and special considerations once diagnosed, test for HCV GT and resistance. CBC, metabolic panel, TSH, if using PEG, hepatic function panel, coagulation factors IL-28B testing, CC homozygote more likely to clear, HBV and HIV co-infection vaccinate if seronegative for hepatitis A/B pneumococcal polysaccharide vaccine, PPSV23, diagnostic procedures/other evaluate for hepatic fibrosis. Indirect markers include multiple clinical prediction models that are based on factors such as age, gender, AST, ALT, platelets, bilirubin. No one model has emerged as the standard. Models include AST to platelet ratio index, APRI, fibrosis 4-score, fibroindex, Thorne's index, HepaScore, and FibroSure. Liver imaging, ultrasound, US, CT scan, MRI, transient US elastography, Mr. elastography. Liver biopsy, gold standard, indications, discordant indirect marker results, concurrent non-HCV liver disease, elastography not available, not necessary if diagnosis of hepatocellular carcinoma, HCC, is definitive based on imaging test interpretation. Biopsy measures grade, degree of inflammation, and stage, amount of existing fibrosis. Scoring systems, BATS in Ludwig, Medivir, International Association for the Study of the Liver, IASL, Medivir, F0 no fibrosis, F1 portal fibrosis, F2 portal fibrosis with few septa, F3 septal fibrosis, F4 cirrhosis, A, necroinflammation. A0 absent, A1 mild, A2 moderate, A3 severe. Treatment general measures report acute HCV to health department. Treat patients with virologic evidence of HCV, except patients with a short life expectancy whose prognosis would not be changed by treatment. Pre-treatment counseling includes a thorough behavioral health and substance abuse history. Treat comorbidities prior to initiating antiviral therapy. Discuss treatment plan and likelihood of success based on individual factors such as BMI, GT, race, stage of fibrosis, and viral load. Sustained virologic response, SVR. Undetectable HCV RNA after 12 to 24 weeks of treatment. This is considered a virologic cure of HCV infection. HCV cascade, only 50% of patients with chronic HCV are diagnosed, 25% are HCV RNA confirmed, 15% are prescribed treatment, and 10% achieve SVR. 3. Medication first-line acute HCV, okay to delay treatment for 12 to 16 weeks after suspected inoculation to allow for spontaneous clearance. Regimen is the same as for chronic HCV. Chronic HCV treatment with traditional agents, pegylated interferon, PEG-IFN, and ribavirin, is often poorly tolerated and no longer preferred. Medications * standard dose common side effects, contraindications A, Elbasvir Grazoprevir, Zapatir, 50 mg/100 mg daily fatigue, headaches, nausea, avoid without PIB1/3 inhibitors or CYP3A inducers. B. Glecaprevir P. Brentasvir, Mayviret, 300 mg/120 mg daily fatigue, headaches, nausea, diarrhea, avoid with atozanavir or rifampin. C. Ledipasvir Sofosbuvir, Harvoni, 90 mg/400 mg daily fatigue, headaches, weakness, irritability, insomnia, dizziness, depression, nausea, diarrhea, myalgia, cough, dyspnea. D. Sofosbuvir Velpatasvir, Epclusa, 400 mg/100 mg daily fatigue, headaches, irritability, insomnia, depression, rash, nausea, weakness. Genotype, regimen, duration, evidence. 4. 1A without cirrhosis, A for 12 weeks A, B for 8 weeks A, C for 12 weeks A, C for 8 weeks B. 1A with compensated cirrhosis, A for 12 weeks A, B for 12 weeks A, C for 12 weeks A, D for 12 weeks A. 1B without cirrhosis, A for 12 weeks A, B for 8 weeks A, C for 12 weeks A, C for 8 weeks B, D for 12 weeks A. 1B with compensated cirrhosis, A for 12 weeks A, B for 12 weeks A, C for 12 weeks A, D for 12 weeks A. 2 without cirrhosis, B for 8 weeks A, D for 12 weeks A. 2 with compensated cirrhosis, D for 12 weeks A, B for 12 weeks B. 3 without cirrhosis, B for 8 weeks A, D for 12 weeks A. 3 with compensated cirrhosis, B for 12 weeks A, D for 12 weeks A. 4 without cirrhosis, B for 8 weeks A, D for 12 weeks A for 12 weeks B, C for 12 weeks B. 4 with compensated cirrhosis, D for 12 weeks A, B for 12 weeks B, A for 12 weeks B, C for 12 weeks B. 5 or 6 without cirrhosis, B for 8 weeks A, D for 12 weeks B, C for 12 weeks B. 5 or 6 with compensated cirrhosis, B for 12 weeks A, D for 12 weeks B, C for 12 weeks B*. Other medications still in use, although recommended for specific circumstances, include Ombitasvir, Paritaprevir, Ritonavir, and Dasabuvir, Ribavirin, Cimeprevir, Daclatasvir, and Voxilaprevir. Alternative regimens may be available but may have limitations for use in certain patient populations or lower quality of supporting evidence. If non-Black, HIV non-infected, HCV RNA 6 MIU/ml. Issues for referral: consult a specialist experienced in HCV care. Refer to liver transplant program if fulminant acute hepatitis, complication of end-stage disease, or HCC. Complementary and alternative medicine: no evidence for effective complementary therapy in HCV/cirrhosis/HCC. Ongoing care follow-up recommendations: treat early to prevent fibrosis. If cirrhosis is present, treatment may not prevent decompensation. Monitor serial viral load only if on antiviral therapy. Some experts recommend abdominal US every 6 months to monitor for HCC. Screen for varices with endoscopy if cirrhosis present. Patient monitoring: serial ALT/AST, renal function, and CBCs for 12-week course. Follow up 4 weeks after starting therapy and 12 weeks after completing therapy. 4-week HCV RNA, if detectable, recheck at week 6. If RNA has increased greater than 10 times, stop therapy. SVR12, Undetectable HCV RNA 12 weeks after completing therapy generally translates to long-term cure. Goal of therapy. SVR decreases risk of portal hypertension, hepatic decompensation, and HCC. Monitor for decompensation, low albumin, ascites, encephalopathy, GI bleed. Diet low fat, high fiber diet and exercise to treat obesity/fatty liver. Extra protein and fluids while on IFN therapy. Patient education. Avoid alcohol, tobacco, and illicit drugs, including marijuana. Refer to rehabilitation/12-step program and monitor for relapse as appropriate. Caution with nutritional supplements and herbal medications, may contain hepatotoxins. http://www.cdc.gov/no more hepatitis. Prognosis for every 100 persons infected with HCV, 75 to 85 will develop chronic infection. 60 to 70 will develop chronic liver disease. 10 to 20 will develop cirrhosis over 20 to 30 years, more rapid if older age at infection, male gender, alcohol/substance abuse, HIV/HBV co-infection, or diabetes/insulin resistance. 15% annual risk of HCC, 36% annual risk of hepatic decompensation. Chronic HCV is curable in 70% of cases. In non-cirrhotic GT2 or 3, cure rate is 90%. Complications. Fibrosis and cirrhosis typically develop within the first 5 to 10 years of infection. Acute/subacute hepatic necrosis, liver failure, HCC, transplant, and complications. Death risk factors for cirrhosis: age, white race, hypertension, alcohol use, anemia, risk for decompensation, diabetes, hypertension, anemia. References 1.